I want to point out, did you notice that in all those numbers, there were over 80,000 people who labored after 2 cesareans in the US from 2014 to 2021? That's incredible. So when someone tells you that doesn't happen, it's absolutely false. Not only does it happen, it is happening, and it is happening even when people are pregnant with twins. Hello. Welcome to the VBAC Facts podcast. I'm Jen Kamel, VBAC Facts founder. And since 2007, our focus has been to provide accurate and objective information on vaginal birth after cesarean and repeat cesarean to parents, professionals, policymakers, and the court, so all decisions can be informed, ethical, and just. Today's topic is vaginal birth after 2 cesareans. I'll share with you some birth stories, walk you through the evidence, and share some recent studies on vaginal birth after 2 cesareans, including one that looks at being pregnant after 2 cesareans with twins. If you want to learn more about vaginal birth after 2 cesareans and you're a perinatal professional, I invite you to join VBAC Facts Professional membership, where we have a continuing education training on vaginal birth after 2 cesareans, which offers nursing contact hours. Also within professional membership is a handout on vaginal birth after 2 cesareans summarizing the evidence. We have it available in English and Spanish, and really the objective is to make it as easy as possible for you to share accurate information with your clients and patients. I'll include links to that in the show notes, or you can just go to vbacfacts.com/membership. First, let's open with some birth stories, because while you know I love the numbers, I love the statistics, and I love all the graphs, let's remember what's behind all of those abstract things. It's people. So let's hear from our readers. Musi from Toronto, Canada, emailed me her story back in October 2023. So when I decided to discuss vaginal birth after 2 cesareans on the podcast, I emailed her and asked if I could share her story with you because it was so powerful. And she agreed. Here's her email. Hi, Jen. Sharing my story in case it can help paint a picture of the VBAC situation in Toronto, Canada, and hopefully help others achieve their dreams. Here it goes. My first 2 deliveries were cesarean, as both babies were in breech position. The first was detected after the due date, so very little I could do at that point. The second was a scheduled cesarean after a failed version performed by a student to my dismay. Back then, I didn't have the knowledge and power and confidence to insist otherwise. But I understand and accept that it was in God's hands. I am so grateful for my amazing children and beautiful family. Nevertheless, my cesarean experiences were extremely difficult. I have issues with anesthesia, and it caused complications with the spinal, multiple failed attempts, to the point of requiring general anesthesia. In short, horrible experiences that I wanted to avoid a repeat at all costs. I always wanted to have a large family. I come from one, and I always wanted to experience giving birth naturally. So I knew that I must do everything possible to have a vaginal birth after 2 cesareans. Especially after my OBGYN, head of department at the second largest maternity ward hospital in Toronto, told me categorically, that's it, only cesareans for you now, nothing to talk about. I knew that I have to fight hard for this. The odds are against me, I felt. By the next time I conceived while at the fertility clinic, I asked my specialist doctor to refer me to an OBGYN who would be open to the idea of a vaginal birth after 2 cesareans. As I already understood, it wouldn't be easy to find. Thank God I was referred to a doctor at the hospital with the biggest maternity ward in Toronto, possibly even Canada, who was willing to discuss it. And at the same time, I contacted a doula who was amazed by my determination and enlightened me on the wonderful work you do at VBAC Facts. For financial reasons, I couldn't sign up for your course, but I did sign up to your emails. That opened up a whole new outlook on the matter for me. If before I felt that I'm putting up a front due to lack of information, now I felt truly confident. It was such a boost. I wasn't shaky inside any longer. I had months of doctor visits where she would try to carefully throw doubts in my decision, always explaining it's so I can make an informed decision, but unnerving nonetheless. I was sent for tests to check the thickness of scar tissue, which came back as 7 millimeters. I'm sure you know this, but that is 1 millimeter below the ideal 8 millimeters meant to increase the risk of rupture. Let's pause. That's false. We do not have strong evidence connecting the thickness of the uterus with a lower or higher risk of uterine rupture. There's a lot of studies out there. There are so many different factors that go into when we compare how all of these various studies were conducted. The short answer is we don't have strong evidence. And I understand why it seems like it would make sense, but the reality is we don't have the evidence to support that. So I just want to throw that in there. Let's go back to her email. And I had to work so hard to focus on the 80% chance of success. In every visit, we again had the conversation about a non-medicated birth, which I kept insisting on since I knew anesthesia does not work for me. I wasn't scared of general anesthesia because I already had that and almost preferred it to a spinal, as ridiculous as it sounds. Anyways, baby was 6 days overdue and I was a little nervous because they told me I wouldn't be induced. And just the general worry of, is my body capable of this? Am I doing the right thing, etc. And then it finally happened. It was literally a dream come true. Labor began at 11 p.m., long drive from where I lived to the hospital, 1.5 hours in early labor. By the way, part of the challenge of VBAC access. The staff was kind of nervous as well, but overall respectful. It really felt like an unusual occurrence. The baby's heartbeat monitor was a nuisance. I think they made a bigger fuss than they would normally due to my history, understandably. Aside for the pushing for too long and subsequent vacuum, it was a surreal experience. I was on a high for weeks. So grateful and elated. In hindsight, I learned many things from this experience. Immense determination is necessary for a vaginal birth after 2 cesareans. It's only accessible in this one single hospital in the entire province of Ontario. Mount Sinai, so for those geographically far, it may not be an option. The widespread misconception that VBAC is a dangerous, considerable risk parents willingly put their baby at. The plain lack of knowledge in the subject and readiness to make false statements is mind-boggling. Thank you again for doing what you do. It is so important, and I wish you much success. Right there, lack of information. I just recorded someone else yesterday for another podcast episode, and that was one of the things that she was saying too. She was saying lack of information in her community was really harming her community because people didn't know they had options. They didn't know what their rights were. And as a result, it was easier for her local hospital that had a VBAC ban for years to maintain that ban because people didn't know what the information said or what their rights were. And as that changed in her community, that VBAC ban fell. So I can't wait to share her story with you. That'll be coming up in the next couple months. So let's share our next VBAC after 2 cesareans birth story from Maggie in New York State. She says, I had an unmedicated vaginal birth after 2 cesareans in April 2024. I also had premature rupture of membranes, so experienced a lot of pressure for interventions to get labor started. After 36 hours with contractions started picking up, so we went to the park near the hospital. I laid on the ground in the dirt in the sunshine next to a pond with swans and birds chirping around me. I know I looked like a crazy person, but was so comfortable while breathing through the contractions in the sunshine. Finally, I knew it was time to go. But as soon as I got to the hospital, my labor stalled. I started to panic. I was told I wasn't in real labor. I almost had a mental breakdown and was feeling very pressured by the midwife in a negative way. She was convinced I wasn't in active labor and that my membranes had been ruptured too long. I understood the risk, so was very close to agreeing to another C-section. As soon as my doula arrived, I agreed to a cervical check and everyone was shocked. I was already 5 centimeters after being told I wasn't in labor and would need a C-section. The midwife was shocked. I was admitted. My doula lowered the lights, encouraged me to walk, used various essential oils and vibrational music. I was left alone to labor and had my daughter 5 hours later while on all fours. I am grateful I was at the hospital because I did hemorrhage. I appreciate the doctors and nurses, but I'm also grateful for standing my ground against unnecessary intervention that allowed me to have a vaginal birth after 2 cesareans. From 5 centimeters to delivery in 5 hours. That's pretty awesome. Licia from Pennsylvania shared her story. I had an unmedicated vaginal birth after 2 cesarean hospital birth at the end of May of last year. I went into spontaneous labor with my first 2 children and made it all the way to 10 centimeters both times, but pushed for 4 and 2.5 hours with no success. Most vaginal birth after 2 cesarean success stories I have read are about women who were induced and/or breech presentation with a second scheduled C-section before having a vaginal birth after 2 cesareans. This is also incredible, and those women are amazing. But I know that when I was looking for success stories for cases like mine, I really couldn't find anything. So I've actually asked her if she'd be willing to come on the podcast and share her whole story, because I agree. Sharing stories like her of someone who got to pushing twice and had 2 cesareans and showing that it is in fact possible. So wait to hear her story as well. Finally, Tamara from Puerto Rico shares that she also had a vaginal birth after 2 cesareans last January. And I love sharing all of the locations of the stories, so that way you can get a sense like vaginal birth after 2 cesareans is accessible. We talked about Puerto Rico, we talked about Canada, we talked about New York State, we talked about Pennsylvania. And let me tell you, there's a lot more stories out there. I'm going to be referencing a study later on. I think it was over an 8-year period, there were 80,000 vaginal births after 2 cesareans in the US. So I want to give you a sense that this is happening. Yes, the rates are low, but that's because so few people have the opportunity. And so that's the barrier. The barrier is not people's bodies aren't capable of doing this. The barrier is finding a supportive facility and provider. And it's not just about finding a provider who is supportive or tolerant or not supportive, right? There's a 4th category of provider. And that type of provider is the provider who may not be supportive, but they may honor your right to decline a cesarean. That is fundamental. Every provider should be able to provide that level of care where they say, okay, I have all the skills to deal with an emergency. I know how to manage labor. And in the event that you have complications, including a uterine rupture, I will be here to be the lifeguard. But I also cannot tell you you have to have a C-section. And I would also add a little asterisk there. They also can't exaggerate the risks of VBAC in order to coerce you. That's not ethically correct either. So as you're out looking for providers, that's a question to ask. It's not just, are they supportive or are they tolerant? The question is, will they honor your legal right to make your own medical decisions and decline a cesarean? And monitor your labor, be there as the lifeguard, but to not intervene unless necessary. Okay, so let's jump into the evidence. And really what I'm going to be talking about today are the top 13 points from the training that I have within VBAC Facts professional membership. So within membership, we go into a lot more detail, a lot more depth, but I wanted to share with you what are the most important things to know from that training. This is relevant to not only parents who are pregnant after 2 cesareans, but also for birth professionals and clinicians. Because again, that inaccurate information not only inhibits our ability to make informed decisions, but it also generates a lot of unnecessary fear. I want you to think about, what do you know about vaginal birth after 2 cesareans? What do you believe? And then I want you to counter that against everything I'm going to share with you. And I want to hear from you. What were you surprised to learn? What was especially shocking or helpful for you? Leave a comment. Let me know. This is how we share the facts. Also, when you leave a comment and leave a 5-star rating for me, that helps the algorithm know that, hey, other people might be interested in this podcast. And that's how we're able to reach a new audience. We're able to reach more people, because really the objective is to reach every single parent who's had a C-section and every single birth professional and clinician. That's my goal. And I mean, hey, if we can throw policymakers and every single attorney who works on cases regarding VBAC in that bucket, let's do it. Let's reach for the stars. This is how we make change. It's with accurate information. That is the very first step. So let's start. So as is the case with vaginal birth after 1 cesarean, vaginal birth after 2 cesareans is a reasonable option that is often difficult for people to access. This difficulty is caused by fear and misunderstanding about the evidence and the risks. And while I have addressed myths about vaginal birth after 2 cesareans in the past, I wanted to explore this topic a little bit further. To help clear up all the confusion, here is an overview of the evidence on vaginal birth after 2 cesareans. First point, let's be clear. Vaginal birth after 2 cesareans is a mainstream, evidence-based, reasonable option supported by national guidelines and medical evidence. Is that statement surprising to you? Okay, let's keep going. As the American College of Obstetricians and Gynecologists, ACOG, asserted in their 2019 VBAC Practice Bulletin number 205, quote, given the overall data, it is reasonable to consider women with 2 previous low transverse cesarean deliveries to be candidates for TOLAC, trial of labor after cesarean, and to counsel them based on the combination of other factors that affect their probability of achieving a successful VBAC. So point 1, vaginal birth after 2 cesareans is mainstream, it's evidence-based, it's supported by the guidelines. Okay, point 2, a prior vaginal birth is not required to plan a vaginal birth after 2 cesareans. Now here's where that confusion comes from. In 2004, ACOG published VBAC guidelines, which stated a prior vaginal delivery was, quote, required in order for someone to plan a vaginal birth after 2 cesareans. This recommendation was removed in the subsequent guidelines published in 2010 and has not resurfaced since. Nevertheless, some clinicians still inform birthing people that unless they have a prior vaginal delivery, they can't plan a vaginal birth after 2 cesareans. Now, given that it can take upwards of 20 years for new evidence to make its way into clinical practice and hospital policy, I want to draw special attention to this obsolete requirement that can be a barrier to access. Point 3, a prior vaginal delivery means higher VBAC odds. While a prior vaginal delivery is no longer required, if someone has had a prior vaginal delivery, they are an especially good candidate for vaginal birth after 2 cesareans. This is because their risk of uterine rupture, one of the most serious potential complications of planned VBAC, has decreased, and their odds of vaginal birth have dramatically increased. And that's per Mercer 2008, and I'll include all the citations as I always do in our show notes. In fact, Mercer reported that the VBAC rate among those with 1 prior VBAC was 88%. This increased to 91% after 2 prior VBACs. This is significantly higher than the rate of 63% among those with no prior VBACs. Now, please note, while the odds of vaginal delivery increases with each prior VBAC, and that's an important thing to remember, especially for those who plan to have a larger family, the risk of uterine rupture does not decrease with each subsequent VBAC. The risk of uterine rupture significantly drops after that first VBAC, but it does not lower if more vaginal deliveries occur, nor does it ever return to the risk level of someone who's never had a uterine surgery. And again, that's per Mercer 2008. If you want to learn more about VBAC, your very first step should be to join my email list. I'm going to include the links in the description, but if you want to just go to vbacfacts.com/report right now, you can download my uterine rupture report where I debunk the top 5 most common myths I've seen about uterine rupture. Go to vbacfacts.com/checklist to download my 5 simple steps to planning a vaginal birth after cesarean. And go to vbacfacts.com/handout to download the top 3 VBAC myths that I bust using the American College of OBGYN's VBAC guidelines. You might be shocked what you think is true versus what ACOG actually says. Let me help you break it down. Join my email list, download my free resources, and continue learning about VBAC with me. Now, I might lose track of our points here because I didn't number them in my notes. But point 4, overall odds for a vaginal delivery are high. Even without a prior vaginal delivery, once someone goes into labor after 2 cesareans, the odds of their having a vaginal birth after 2 cesareans are good. One study reported rates similar to those with 1 prior cesarean, about 75%, and that was McCone's 2005. Another study, Landon 2006, reported a significant drop from 74% after 1 cesarean to 67% after 2. But the largest systematic review of over 5,600 vaginal births after 2 cesareans reported only a modest drop from 77% to 72%, and that is Tassin 2010. While there is one recent study that reports much lower VBAC rates, only 39%, the authors of that study acknowledged that number reflected the overall low national VBAC rate rather than the physical ability of people to deliver vaginally after 2 prior cesareans, and that was from Dombrowski 2020. In other words, in a climate where physicians may recommend a cesarean earlier than necessary for a vaginal birth after 1 cesarean, they may also follow that pattern for a planned vaginal birth after 2 cesareans. That study reported that vaginal birth after 2 cesarean rates were higher in hospitals that had higher level NICUs or where midwives attend births. Now, point 5, the evidence on vaginal birth after 2 cesareans is limited. So when we look at the available evidence on vaginal birth after 2 cesareans, we can see that while there have been quite a few studies published, the number of people included in the studies varies greatly. The largest recent studies were published by McCone et al. In 2005, Landon et al. In 2006, Dombrowski et al. In 2020, Mao et al. In 2024, and Mustafa et al. In 2025. I will focus on Mao and Mustafa a little later. First, McCone's and Landon are the 2 vaginal birth after 2 cesarean studies cited in ACOG's 2019 VBAC guidelines, whereas Dombrowski focused on all people who birthed after 2 cesareans in California between 2010 and 2012. Mao is a large systematic review and meta-analysis, whereas Mustafa focuses on being pregnant with twins after 2 cesareans. So we're going to talk about it all. So first, those first 3 studies, McCone, Landon, and Dombrowski. All those studies were similarly sized, ranging from 975 who labored after 2 or more cesareans in Landon, 871 of whom had 2 cesareans, to McCone and Dombrowski, which respectively included 1,082 and 1,228 people who labored after 2 cesareans. In fact, prior to Mao and Mustafa being published in 24 and 25, we had to go all the way back to 1994 to get the next sizable study published by Miller, which included 1,586 people who labored after 2 prior cesareans over the course of 10 years. Given that we have this collection of small studies, in 2010, Tashin combined them into a larger study called a systematic review. This enables us to compare vaginal birth after 1 cesarean to vaginal birth after 2 cesarean outcomes, as well as vaginal birth after 2 cesareans versus a scheduled 3rd cesarean. Tashin included 5,666 people who labored after 2 cesareans. So what did these studies find? Well, that's where we get to point 5. Vaginal birth after 2 cesarean uterine rupture risk is low. So some studies don't report a difference in uterine rupture risk between vaginal birth after 1 cesarean and after 2 cesareans. Others do. As a result, it's hard to say definitively how the risk evolves for those who have 2 prior cesareans. It's likely that the risk increases, but how much it does, no one can say for sure. And that's an important thing to remember. So why do I say this? Let me share it with you. So McCone 2005 reported a uterine rupture rate of 1.8% among the 1,082 people who labored after 2 cesareans. Now, this was significantly higher than those laboring after 1 cesarean, 0.9%. Now, Landon from 2006 reported a uterine rupture rate of 0.9% among the 975 who labored after 2 or more cesareans. And this was not statistically different from the 0.7% among those with just 1 prior cesarean. Now, let's go all the way back to Miller in 1994. And it's quite an old study, but it did include almost 1,600 people laboring after 2 cesareans. And they reported a uterine rupture rate of 1.8%, the same as McCone's. Now, Tasheen, which included McCone's, Landon, Miller, as well as a smattering of smaller studies, reported that the risk of uterine rupture was higher after 2 cesareans, 0.7% after 1 cesarean versus 1.6% after 2 cesareans. As a result of McCone's and Landon's studies, most people believe that the rate of uterine rupture during a planned labor after 2 cesareans to be somewhere between 0.9% and 1.8%. And these are the figures cited in ACOG's VBAC guidelines. But here's the catch, and I just want to ask you, what do you think the catch is? Okay, here's the catch. Those rates are influenced by high rates of induction and augmentation. So in these 2 studies, many labors were induced. That means they were started artificially by means of medication, or augmented. That means that medication was given to speed up a labor that was already in progress. Now, we know that induction and augmentation likely increase the risk of uterine rupture. Therefore, it is likely that the reported 0.9% to 1.8% rate of uterine rupture is higher than the rate would be in labors that are not induced or augmented. Now, spontaneous labor in these studies means someone whose labor began and progressed naturally without the use of medications like Pitocin. So let's look at McCone and Landon. How many people labored spontaneously? In McCone's study, only 35% labored spontaneously. In Landon's, it was 51%, including people with 2 or more cesareans. And while Miller made reference to the fact that a number of labors were induced or augmented, Miller did not provide further details. Similarly, while a number of labors were induced in Dombrowski's study, they did not report the breakdown between induced, augmented, and spontaneous labors. And so that's something that's really key. When you're looking at studies and they're reporting a uterine rupture rate, one of the important questions to ask is how many people in this study were induced, how many were augmented, how many labored spontaneously, and does the study report a uterine rupture rate for all 3 categories? That's one of the ways that studies can be used to misrepresent the facts, is by providing a rate of uterine rupture that included a population where, say, 70% were induced or augmented. If we want to get a baseline idea of what the rate of uterine rupture is after 2 prior cesareans, we want to look at what the uterine rupture rate is in a non-induced, non-augmented labor. But does that number exist? So let me show you. So the often cited uterine rupture rate after 2 cesareans is 0.9 to 1.8%. That's based on a 49% to 65% induction and augmentation rate. This is an important factor to consider anytime we discuss vaginal birth after 2 cesareans. As a result, it's possible that the rate of uterine rupture during a spontaneous labor after 2 cesareans is lower than 0.9 to 1.8. In fact, McCone revealed that of the 379 people who labored spontaneously, 3 had a uterine rupture for a rate of 0.8%. So, can we say that the true risk of uterine rupture during a planned vaginal birth after 2 cesareans is 0.8%? No, we cannot. And this is why. This is a single data point, and with such a small sample size, less than 400 people, we can't lean into that number as the answer. Meanwhile, Landon, Dombrowski, and Miller did not reveal the rate of spontaneous uterine rupture in their studies. So we have a single subset of 379 people from one study where we can clearly point to a uterine rupture rate associated with spontaneous labors. But such a small sample size is not strong evidence. But with the knowledge that induction and augmentation potentially increases uterine rupture risk, it is reasonable to assert that the rate of uterine rupture during spontaneous labor could be lower than the 0.9% to 1.8% range reported by McCone and Landon and cited in ACOG's VBAC guidelines. However, as we do not have studies on spontaneous uterine rupture during a planned vaginal birth after 2 cesareans, we do not have solid data on the risk. And this is, again, where transparency is important. Being clear on what we know and what we don't is essential, especially when providers relay information to birthing people. It is fundamental to developing rapport and trust, as well as navigating important decisions around labor and birth. Let's review a very important concept that influences not only how we communicate information, but how others receive it. That concept is the difference between relative risk and absolute risk. Now, relative risk compares outcomes of different situations. Absolute risk tells us how often an outcome occurs. This is the difference between saying a specific risk doubles, which is relative risk, or saying the risk is 2% or 1 in 50, so that's the absolute risk. Point number 7, other vaginal birth after 2 cesarean maternal and neonatal risks are low. What about other complications associated with planned vaginal birth after 2 cesareans? Within vaginal birth after 2 cesareans, there are a couple of ways to look at risk. First, how risk compares between those who labor after 1 cesarean versus those who labor after 2 cesareans. A systematic review on vaginal birth after 2 cesareans, Tazeen, 2010, found that while maternal complications were relatively higher after 2 cesareans, the absolute rates are small, such as uterine rupture, 0.7% versus 1.6%, blood transfusion, 1.2% versus 2%, and hysterectomy, 0.2% versus 0.5%. The same pattern held true for neonatal outcomes. The rate of stillbirth, postnatal death, and injuries associated with oxygen deprivation increased from 0.05% to 0.09% for those laboring after 1 versus 2 prior cesareans. So you can see the risk increases, but it's still low, right? So you can easily say that risk almost doubles. Again, that's a way that people manipulate what the evidence says to fit their agenda. So you could accurately say, yes, that risk increases, it almost doubles. It goes from 0.05% to 0.09%. But the accurate thing to do is then to say the absolute risk of that event occurring is still very low. 0.09% is a very low complication rate. How do these outcomes compare between a scheduled 3rd cesarean and a planned vaginal birth after 2 cesareans? That's another way that we can look at the risk. The risk of uterine rupture is clearly higher with a planned VBAC. That's never a surprise, right? With a planned VBAC after 2 cesareans, it was 1.1% versus 0.1% in a 3rd cesarean. But transfusion, hysterectomy, and NICU admission were all similar. Transfusion, the rate was 1.7%, hysterectomy, 0.6% versus 0.4%, and NICU admission, almost 9% and 8.5%. So all of those were similar between planned vaginal birth after 2 cesareans and a 3rd cesarean. For perinatal outcomes, the risk of stillbirth, postnatal death, and injuries associated with oxygen deprivation was higher with a vaginal birth after 2 cesareans, 0.09%, than with a scheduled 3rd cesarean, 0.01%. But again, the absolute risk was quite low. The study concluded that the data on perinatal outcomes does not indicate a statistical difference between vaginal birth after 1 cesarean, vaginal birth after 2 cesareans, and a scheduled 3rd cesarean. The 2 largest modern studies included in this systematic review, as well as the review itself, concluded that while the relative risks were higher with a vaginal birth after 2 cesareans, the absolute risks were still low. Thus, vaginal birth after 2 cesareans is a reasonable option per McCone associated with increased risk that was described by Landon as statistically small, and Tassin recommends people should have the option of a carefully monitored vaginal delivery available to them. Further, Dombrowski reported that when comparing those who labored after 2 cesareans versus those who planned a 3rd cesarean, there were no differences in maternal outcomes and only a modest increase in newborn complications, from 1.4% to 2%. This is why ACOG's VBAC guidelines support access to vaginal birth after 2 cesareans. Point number 8. Medical evidence can be used to manipulate. Even though the medical evidence supports vaginal birth after 2 cesareans, there are those who will take slices of this information and use it to encourage birthing families to schedule repeat cesareans. This is because people can look at the same study and the same numbers and do one of 2 things: be transparent about the findings and put it into perspective so that the audience they're talking to can easily understand the facts and make their own decision, or magnify and highlight selected risks to sway the audience towards a specific decision. Many birthing people report being coerced into a 2nd or 3rd repeat cesarean by providers who exaggerate the risk of their baby dying during a planned vaginal birth after 2 cesareans. Let's talk a bit about that risk. Per our systematic review, the risk was higher with a labor after 2 cesareans versus a 3rd cesarean. And remember, that was 0.09% versus 0.01%. So let's think about how someone can communicate this information. If we wanted to deter someone from planning a vaginal birth after 2 cesareans, we could focus on the relative risk. And we could honestly say, the risk of your baby dying is 9 times higher if you plan a vaginal birth after 2 cesareans. That statement would be correct, citing this piece of research. But if we wanted to be transparent and honest, we could say that the relative risk was higher, but the absolute risk at 0.09% for labor after 2 cesareans and 0.01% for an elective 3rd cesarean is quite low with both options. One could express the risk in another way. Rather than the abstract percentage of 0.09%, we can change that into a ratio of 1 in 111 labors after 2 cesareans, which further frames the small absolute risk. Beyond that, we could explain, as the authors of this systematic review do, that the studies in which these numbers are based are 10 to 20 years old with less advanced neonatal facilities. This means that these neonatal morbidity figures may not be representative of current practices given considerable advances in neonatal care in recent years. In other words, it's likely that the current neonatal outcomes for planned vaginal birth after 2 cesareans could be better than those reported in this 2010 systematic review. This is something to be aware of when looking at older VBAC research. However, ignoring this context and nuance is exactly how some providers use published medical research to focus solely on the relative risk number and obscure the full picture in order to obtain, quote, consent for a 3rd cesarean. Now, I want to touch on these 2 more recent studies. First, Mao 2024, entitled Trial of Labor versus Elective Cesarean Delivery for Patients with 2 Prior Cesarean Sections. It's a systematic review and meta-analysis. What that means is they went out, they found all the research on vaginal birth after 2 cesareans versus a 3rd cesarean. They looked at it and they combined all the results for that research to give us a summary. They reported a higher rate of maternal mortality among planned vaginal birth after 2 cesareans in comparison to an elective repeat cesarean. I was really curious, how did they come up with that conclusion? Now, maternal mortality is fortunately very rare, so we need very large sample sizes, tens of thousands, preferably really hundreds of thousands, in order to measure the rate of maternal mortality accurately. They had 13 studies with a combined sample size of over 100,000 people with 2 prior cesareans. Great. That should satisfy us, right? No. Because when we look at how many of those 101,000 who labored after a cesarean, it is a small fraction, not nearly enough to accurately measure maternal mortality. So of our 13 studies included, we had just shy of 22,000 labors after 2 cesareans. That's 22% of our sample size. And 22,000 is a pretty small number upon which to measure maternal mortality. Now, when looking specifically at maternal mortality, they only included 8 studies, which included 19,511 planned VBACs and about 34,000 elective repeat cesareans. Not enough to accurately measure maternal mortality. Mao also said that, quote, no correlation was found for other maternal outcomes, including blood transfusion, hysterectomy, or postpartum hemorrhage. Additionally, when the study looked at neonatal outcomes, such as APGAR scores, NICU admission, and neonatal mortality, these two were similar between labor after 2 cesareans and elective repeat cesarean section. If you are a perinatal professional who wants to learn more about vaginal birth after 2 cesareans, we dive into all the details in our continuing education training, The Truth About Vaginal Birth After 2 Cesareans, Risks, Rates, and Outcomes. And it's approved for 2.4 nursing contact hours. Check it out in VBAC Facts Professional membership. In fact, membership offers over 20 nursing contact hours on a whole host of topics, from fetal monitoring during planned VBAC to single versus dual layer suturing to our signature course, The Truth About VBAC for Professionals, which provides an excellent foundation on not only the medical ethics, national guidelines, medical evidence, politics, malpractice, factors of uterine rupture. We break down the most critical questions that you and your clients have. If you want to learn more and provide your families who've had cesareans with the very best VBAC education and support, go to vbacfacts.com/membership and enroll today. If you are a parent who's had a cesarean and want to learn more about the VBAC evidence so you can conquer your fears, eliminate confusion, and confidently make decisions without wasting thousands of hours on the internet, then check out our online self-paced course, The Truth About VBAC for Families, at vbacfacts.com/courses. I also offer consulting for parents, professionals, those working on VBAC and maternal health policy, as well as attorneys who are working VBAC cases. You can learn more at vbacfacts.com/consulting. If you want to bring a VBAC Facts continuing education training to your community, learn more at vbacfacts.com/speaking. Remember, VBAC Facts is a continuing education provider through the California Board of Registered Nursing, and the CEs we issue are accepted by multiple medical and health licensing bodies throughout the United States. So, Mustafa 2025, Trial of Labor After Cesarean Delivery in Individuals with Twin Pregnancies and 2 Prior Cesareans. What a fascinating study. I was so excited to read this. So, what did they look at? They looked at people who were pregnant with twins after 2 prior cesareans. They looked at short-term maternal and neonatal outcomes. Now, this is another birth certificate study, and I love these studies for the high numbers, but you always have to take them with a grain of salt. This is why it's so important to look at multiple studies on a topic, because each study is conducted a little bit differently. But if we have enough strong studies on a specific topic, and they're all pointing towards the same direction, then we know we're getting closer and closer to the accurate, true answer. I loved how they conducted the studies. They compared people who were pregnant with twins after 2 cesareans and labored, people who were pregnant with twins after 2 cesareans and had an elective repeat cesarean, people who were pregnant with 1 baby after 2 cesareans and labored, and then people who were pregnant with twins after 1 cesarean who labored. Pretty cool, right? Like, this is a great study. I've never seen a study that compared these 4 different populations. Among the people who were pregnant with twins after 2 cesareans, 38% had a VBAC. Among the people who were pregnant with twins after 1 cesarean and labored, 62% had a VBAC. So that's a dramatic drop, right? Now, that low VBAC rate could be because providers might have had a lower threshold of when they called that repeat cesarean. That could have contributed to this relatively low VBAC rate. But also, we could look at this VBAC rate another way. We can say, look at this. 40% of people who labored after 2 cesareans and were pregnant with twins had a VBAC. So do you see how we can use that number and we can look at it 2 different ways? It all depends about how we frame that number. When I started reading a full text, this statement in the introduction really stood out to me. Although some studies have suggested that individuals with twin pregnancies have lower rates of successful TOLAC in comparison with those in singleton pregnancies, other studies report similar success rates. Anytime I see a variation in outcome like that, one of the things that immediately pops to mind is provider preference and hospital support. Because when you are talking about someone who is pregnant with twins, inevitably, you're talking about having access to providers who are trained in vaginal breech delivery, because you might have one of those twins end up being breech. And that's something that providers get to be trained and comfortable with. Between 2014 and 2021 in the US, there were over 92,000 pregnant individuals and over 106,000 neonates, babies, included in this analysis. Now, there were 632 individuals with twin pregnancies and 2 prior cesarean deliveries who underwent TOLAC. Incredible that we're able to get those numbers. It's still relatively small, but considering that we're looking at people who labored after 2 cesareans and were pregnant with twins, I'm thrilled to have over 600 people. We also had 9,400 people who were pregnant with twins after 2 prior cesareans and had a scheduled cesarean. We had about 3,700 who were pregnant with twins after 1 prior cesarean who labored, and then about 79,000 who were pregnant with 1 baby and 2 prior cesareans who labored. I want to point out, did you notice that in all those numbers, there were over 80,000 people who labored after 2 cesareans in the US from 2014 to 2021? That's incredible. So when someone tells you that doesn't happen, it's absolutely false. Not only does it happen, it is happening, and it is happening even when people are pregnant with twins. Something that might be of interest to you is that the people who were pregnant after 2 cesareans and were pregnant with twins, some of them were induced. About 13% were induced and about 11% were augmented. Of note is among the 632 individuals with twin pregnancies and 2 prior cesarean deliveries who labored, no one experienced a uterine rupture. Now, let me ask you a question. Does that mean that the rate of uterine rupture when you labor after 2 cesareans with 2 babies is 0? No, it doesn't. It just means that's what this one study found. One of the things with small sample sizes is that sometimes the rare event you want to measure doesn't even happen at all, as is this case. And sometimes, due to chance, it happens more often than you would expect in that small population. And that's why whenever we're measuring anything, but particularly when we're measuring things that happen rarely, you want a larger sample size, because the bigger net you throw out there, the more likely you can accurately measure how often those events occur. Remember how earlier I mentioned how they defined uterine rupture? Well, here is where they specify. They say, quote, CDC data do not provide a particular definition of uterine rupture. Hence, some uterine scar dehiscence might have been documented as rupture, resulting in misclassification bias. This is the challenge with uterine rupture statistics, and this is why I advocate for when anyone is measuring uterine rupture, for us to have 3 categories: uterine rupture, suspected uterine rupture, and uterine dehiscence. So that way you're able to code specifically what happened. Was there a C-section done and there was an actual uterine rupture? Was there a C-section done because they thought there was a uterine rupture, but there wasn't? Or during a routine repeat C-section, did they see a dehiscence? We need to be very clear. When are we describing uterine rupture, which is a medical emergency, and dehiscence, which is asymptomatic and typically doesn't pose a problem? To include both of those events under the label of uterine rupture exaggerates the rate of uterine rupture and confuses parents and medical professionals. In conclusion, the authors say, quote, no significant differences in other maternal and neonatal outcomes were detected in comparison with the other twin groups, although the power to detect differences was limited due to the low rate of complications. These findings suggest an opportunity for patient autonomy and shared decision-making in cases of twin gestation with 2 prior cesarean deliveries. Individualized patient counseling is crucial to weigh the risks and benefits of TOLAC in the context of previous obstetric history, current pregnancy characteristics, and patient value and preferences. This is a hopeful study. This shows that not only are people pregnant after 2 cesareans and laboring, but they're doing so even pregnant with twins. Okay, so takeaway number 8 is induction is not contraindicated in vaginal birth after 2 cesareans. And we saw that just right now in that study that we were looking at people who are pregnant with twins after 2 cesareans. But let me share with you more. Induction after 2 cesareans is not contraindicated per ACOG's VBAC guidelines. And this is a good thing because in the absence of induction, when a medical indication arises that necessitates delivery, an induction means that a vaginal birth could still occur, avoiding the risks associated with another surgical birth. Risks and benefits, including areas of unknown risk, must be discussed so birthing people can make the medical decisions that are best for them. Now, are there any studies specifically on vaginal birth after 2 cesarean induction? We were able to identify a small study of 152 vaginal birth after 2 cesarean inductions, which concluded that VBAC rates as well as maternal and neonatal outcomes were the same for those with 1 and 2 prior cesareans. Now remember, 152 people, very small sample size, but I share it with you because it's the evidence we have available. So comparing an induced labor after 2 cesareans to a scheduled 3rd cesarean, this study found that maternal and neonatal outcomes were similar, and this was Miller and Grobman 2015. Point number 9, cesarean surgeries carry their own risks. So often when vaginal birth after 2 cesareans is discussed between a provider and a patient, the conversation is limited to the short-term risks of a labor after cesarean like uterine rupture, hysterectomy, or blood transfusion. Now, this holds true for the existing studies on vaginal birth after 2 cesareans. However, several of those studies, including McCone, Landon, Dombrowski, and Tasheen, all mention the importance of considering long-term consequences, especially when it comes to the risks of multiple repeat cesarean sections. In fact, the risk of certain pregnancy, delivery, and postpartum complications increase with each cesarean birth. And these include risks of serious placental abnormalities like placenta accreta, where the placenta abnormally attaches to the uterine wall, and placenta previa, when the placenta attaches close to or over the cervical opening. Hysterectomy, which again is the surgical removal of the uterus, large blood transfusions as a result of excessive bleeding, surgical injuries most commonly to the bladder, bowel, or ureters, ICU admission, infection, post-operative ventilator, operative time, and hospital stays. And this is all from Silver 2006. Your ureters are the tubes that connect your kidneys to your bladder. And you love your ureters. You may not even know you have them, but believe me, they perform an incredibly important function. When we have a surgical injury to the ureter, that is a significant complication. The risks of placenta accreta and hysterectomy in particular are significant. And this is what Silver said, quote, women having their 4th or more cesarean delivery had a 9 to 30-fold increased risk of placenta accreta and a 4 to 15-fold higher risk of hysterectomy. Now, is that relative risk or absolute risk? That's relative risk, right? I want to get you the absolute risk. Silver refers to this dramatically higher risk of placenta accreta. In his study, he found that during the second cesarean, someone's risk of placenta accreta was 0.31%. That increased to 0.57% in the third cesarean, over 2% in the fourth cesarean, 2.33% in the fifth cesarean, and almost 7% in the sixth cesarean. He talks about hysterectomy. During the second cesarean, the risk of hysterectomy was 0.4%. That increased to 0.9% in the third cesarean, 2.4% in the fourth cesarean, 3.5% in the fifth cesarean, and 9% in the sixth cesarean. The thing to keep in mind is that there is a symbiotic relationship between accreta and hysterectomy, because many people who have accreta end up requiring a hysterectomy in order to control the otherwise uncontrollable bleeding that can occur. That is why those two events, along with bleeding, are all happening simultaneously. That is one of the reasons for excessive bleeding and hysterectomy, but certainly not the only reason as the number of cesareans increase. 4 years later, that same physician researcher warns, quote, "Indeed, placenta accreta has now become the most common reason for cesarean hysterectomy in developed countries." Further, scar tissue within the abdominal cavity called adhesions can develop after abdominal surgery like cesareans, and adhesions can increase with each subsequent surgery. For those who have another cesarean, adhesions are associated with longer operative times. This can increase blood loss and surgical injuries, as well as potentially compromise neonatal outcomes in an emergency cesarean. That's because those adhesions can make the surgical field more complicated, and it can be more difficult to visualize the anatomy and be able to cut what you intend to cut and not cut things accidentally. From a cesarean have also been associated with chronic pain and bowel obstructions years after surgery. Anyone with a history of cesarean birth who is experiencing symptoms consistent with a bowel obstruction should be screened immediately, given the risk of death associated with delayed diagnosis. But how prevalent are adhesions? Well, one study reported that 46% of those having their third cesarean had multiple adhesions. Another found that 83% of those having their fourth cesarean had developed pelvic adhesive disease. As a 2010 article warns, these long-term maternal cesarean complications must be factored into the risk-benefit ratio for women considering vaginal birth after cesarean delivery. Now, while most people will not experience serious complications with repeat cesareans, this is also true among those who plan a vaginal birth after 2 cesareans. Point number 10. The option of planned vaginal birth after 2 cesareans has psychological implications. It is really important for clinicians, friends, and family members to understand that the choice to have a VBAC is not just about a baby coming out of a vagina versus an abdominal incision. It's about being heard, respected, and seen. It's about the birthing person feeling like they have some control over what happens to their body and have the right to make their own medical decisions rather than being forced. It's about feeling the power of one's body, the power of everything their body can do. Within this space, there is a risk of causing trauma or an opportunity to heal it. Right now, the system is causing trauma by leading people to believe that their only option is a third cesarean, coercing them into multiple repeat cesareans by remaining silent on the risks those surgeries introduce is common. Feeling like you are trapped, overpowered, and ignored is not only a horrible setting in which to welcome your new baby, it's a recipe for increasing the risk of developing perinatal mood disorders in the postpartum period. Point 11. Planning a vaginal birth after 2 cesareans can be challenging. Despite the evidence and guidelines supporting safety and access to vaginal birth after 2 cesareans, many people in the U.S. find planning one to be challenging. While 80% of people with no prior cesareans plan a vaginal birth, once someone has a single cesarean, that number drops to only 20%. That's right, only about 20% of people labor after 1 cesarean. After 2 or more cesareans, that number drops further to 7%. A more recent study based on the birth certificate data in California, Dombrowski 2020, they reported only 2.9% of people labor after 2 cesareans. That study found that teaching hospitals with higher-level NICUs, lower malpractice insurance premiums, and midwives who attend births were more likely to support labor after 2 cesareans. Unfortunately, access to vaginal birth after 2 cesareans depends on geography. The percentage of people who labor after 2 cesareans and actually have a vaginal birth after 2 cesareans varies dramatically in the medical literature from 9% to 69% for those who labor and 45% to 89% who actually have a VBAC. Such a massive range is indicative of unequal access to care, including hospitals that ban VBAC or do not offer midwifery care. The ability to plan a VBAC depends on the providers in the community, at the very least, their willingness to honor someone's right to decline a cesarean, even if they do not agree with that decision, but their willingness to stand by and be a lifeguard and offer emergency care if needed. That's what we fundamentally baseline need. If there are no local options, then vaginal birth after 2 cesarean access depends on the birthing family's ability to travel to obtain care. As we know, having to travel long distances can disproportionately limit the care poor people and BIPOC receive. Point number 12. People can decline a repeat cesarean. One of the reasons why so few people labor after 2 cesareans is because their provider first suggests and then pressures them to schedule a 3rd cesarean. They never have an opportunity to labor. As a reader shared with us, when I was going for my vaginal birth after 2 cesareans, I got to my 36-week appointment only to be forced to sign the consent form for a C-section at 39 weeks because, quote, no one at this hospital will support you to have a vaginal birth after 2 cesareans, quote. Well, I just had a successful, unmedicated vaginal birth after 4 cesareans at the very same hospital. They may not have supported it, but as the birthing mother, I have rights. I am so glad I fought for it. It was the most healing and empowering birth. There's a lot there. First, this woman wasn't given a choice. But there's something more. That notion that no one will support her. As I said before, what about respecting her right to decline surgery? No support is required, just providers with a willingness to respect a birthing person's right to decline any intervention and specifically a cesarean. That is based on global human rights law and ethics opinions straight from the American College of OBGYNs. While they have maintained this truth for years, their 2019 committee opinion refusal of medically recommended treatment during pregnancy is crystal clear. Quote, the use of coercion is not only ethically impermissible, but also medically inadvisable because of the realities of prognostic uncertainty and the limitations of medical knowledge. Okay, let's pause for a second. What does that prognostic uncertainty mean? That means that no one's able to see into the future. So they're saying because we know that some things have certain risks, some things have elevated risks, but we still can't identify, will you be the person to experience that risk or not? That is prognostic uncertainty. Because no one can see into the future and we have limitations in medical knowledge, we can't coerce people to do things. Let's continue with what ACOG says. As such, it is never acceptable for obstetrician gynecologists to attempt to influence patients towards a clinical decision using coercion, end quote. In other words, OBGYNs cannot predict the future. As a result, they cannot ethically force people into a specific decision. This ethical stance does not disappear once someone has a cesarean. It doesn't matter what hospital policy says. It doesn't matter if there is a formal VBAC ban which, quote, requires repeat cesareans and doesn't allow VBACs. Coercion has no place in obstetrics. Everyone has the right to decline a cesarean, even if you have 3 or 4 prior cesareans, even if you have a classical cesarean. These are all clinical scenarios that fall under that same ethical umbrella. This is a time where we talk about what we know from the evidence and risks and benefits, and then create space for informed decision-making. Point 13. Home birth after 2 cesareans is sometimes the only option. And I really want clinicians to hear this. Due to the fact that it can be exceedingly difficult for people to have a vaginal birth after 2 cesareans in a hospital, and when I say that, what makes it exceedingly difficult? Providers who prefer repeat cesareans, hospital policies that ban VBAC, nursing staff that can be really anxious and fearful. All of those factors can come together and make it really hard for someone to achieve VBAC. How do we counter that? The first step is to know the facts. And that's why, if you are in those categories, I'm thrilled that you're here. This shows your commitment and dedication to providing the best VBAC education and support. Okay. Because it's so difficult to have a vaginal birth after 2 cesareans in a hospital, some find that the only way for them to avoid a cesarean birth is to plan a home or community birth with a community midwife. As a reader shared with me, vaginal birth after 2 cesareans is absolutely an option and possible. I had to jump through hoops to find a supportive provider with my first attempted VBAC turned CBAC, cesarean birth after cesarean, after much fear-mongering. I had a successful vaginal birth after 2 cesareans at home 5 months ago. It was amazing and healing. The data on home birth after 2 cesareans is very limited, so the risks are unknown. There are many factors that impact the safety of home and birth center birth, including the quality of collaboration between those community healthcare providers and hospitals. In general, studies on home VBAC have found higher VBAC rates than those typically seen in hospitals, upwards of 87%. However, access to home birth varies greatly due to laws, rules, and common practice driven by physician groups in many places that prohibit midwives from attending VBACs either inside of a hospital, in the home, or in birth centers. These policies decrease VBAC access and increase the number of cesareans. Restrictions on midwifery options, coupled with some patients' distrust of hospital-based providers, increases the incidence of unattended births. Now, those are births that take place intentionally without the presence of a medical or midwifery professional. Okay, point number 14. Vaginal birth after 2 cesareans is not a selfish choice. Planning a labor after 2 cesareans is a reasonable, mainstream, and evidence-based option for all of the reasons we discussed. However, access remains a challenge, especially for those who have a prior vaginal delivery, had their cesarean for breech, or want more children per Dombrowski 2010. Vaginal birth after 2 cesareans plays an important role in reducing repeat cesarean delivery and associated maternal morbidities. If someone wants to plan a vaginal birth after 2 cesareans, then they should have the opportunity now rather than after 3 or 4 cesareans when the overall risks are higher. This is why it is also so important when someone is pregnant after 1 cesarean for them to have access to VBAC. Let's ensure that people have equal access to birthing options when their risks are the lowest. Each cesarean increases the risks and lowers the likelihood that they will be able to have a vaginal birth after cesarean. And why is that? That's not because their bodies are broken. That's not because they can't do it. It's because of these various non-medical factors that inhibit access to VBAC. And those factors get stronger and more difficult to overcome the more C-sections someone has. If we want to improve healthcare, we need to ensure that everyone pregnant after 1 cesarean has a real, genuine opportunity to choose VBAC or not. That is very different than what is happening right now in the U.S. We can do better. That is our obligation. Okay, so that's it for this week. Don't forget to leave a 5-star review. If you know someone who would benefit from this podcast, please share it. And until next time, I'm Jen Kamel, VBAC Facts founder, and don't you forget what we're about. Since 2007, our focus has been to provide accurate information on vaginal birth after cesarean and repeat cesarean to parents, professionals, policymakers, and the court. so all decisions can be informed, ethical, and just. I'll see you in 2 weeks. Take care.